Safety Translational Research Centre, which is a part of the Institute of Global Health Innovation. I just want to briefly introduce this event, which is Collaborating for Quality, part of our networking series between really our trust here at Imperial, our college, and our broader IGHI network. Unfortunately, we can't leave these doors open, which is sort of very frustrating situation. But I just want to say that a few, probably a year or so ago, Bob Claver and Bob's a consultant paediatrician here in our trust, but also the Associate Medical Director leading quality improvement, and kind of had this idea that actually our team in the Patient Safety Centre and the Quality Improvement team were working on really similar ideas, and we wanted to find a way to unite our teams and create a bit of lasting relationships and connections between the two. So we thought, why don't we do something informal with wine, nibbles, and a bit of a hook to hang everything on in a presentation about a topic that's interesting to all of us, and hopefully generate some good connections, but also some input into the work that we're all doing. So we ran 3 last year, they went very well, took some of your feedback about those events, and my colleague Mary Helen has taken this over, really professionalised what the event is and created a bit of a community around it, so I'll let her say a bit more and introduce our speakers tonight, but mostly thank you for joining us. Mary Helen?
So welcome again. It's been quite exciting, I think, to be organizing this session. I think it's quite a unique opportunity that we have to be connecting researchers and clinicians, among other actors as well. Besides organizing this particular project, I also run the Leading Health Systems Network, and that's a network of international healthcare providers. So we're really excited also to be sharing today's session with an international audience that is quite keen to learn about what we do at Imperial and at St. Mary's Hospital. So if you have any specific interest for future events, please feel free to chat with me after the event. I'm happy to consider any of your interests and thoughts for future events. And with that, I will leave it to our speakers.
Thank you. Thanks for coming out after hopefully everyone had a good Easter holiday. So we are going to be talking a bit about, first of all, how many of you are familiar with the Behavioural Insights team? Okay, great. It's good if you're not, because we're going to give you a bit of a background before we get into the project of reducing clinician burnout. Just to give you an introduction, I'm Emily, and this is my colleague Alix. We both work at the Behavioural Insights team. I work on the education, so I'm a senior advisor, and any kind of medical questions, I'm definitely having imposter syndrome here because I'm not in the medical field, but rather in education. But I've worked with teachers and educators in various countries to try to reduce burnout, which is why I'm leading this project. But Alix is actually the expert as a medic herself, so she can answer any technical questions that you may have. So just to give a bit of an outline, we're going to have a little warm-up activity to get the neurons firing. I realize it's about almost 6, so we might be a bit sleepy, have a bit of wine in us, and then we'll give you an introduction to who we are, what the Behavioural Insights team does, and what are Behavioural Insights in general. And then Alix will be talking about why this is relevant for patient safety, the EAST framework, so how we apply behavioural insights to different challenges and problems. And then finally, we'll get on to the topic of how we're going to apply behavioural insights to reduce clinician burnout. All right, so if everyone could take a moment, I'm going to show you a series of words. Don't write them down, just try to remember them. So we're going to go quite quickly. I can't remember which one it ends on. Okay, take a look at these. Okay, now take 60 seconds to write down as many words as you can remember.
You've taken extra 30 seconds to find your paper.
Yeah. No cheating over there. Notice. Eyes on your own paper. Okay. So, if everyone just raises your hand if you remembered the word bed. Fantastic. Raise your hand if you remember the word wake. A few. Blanket. Okay. Drowsy. Couple. And sleep. Great. So actually, the fun trick is that sleep was not on this list at all. And it's the one that everyone remembered most. So if you're feeling a bit embarrassed, you're in good company. So this has been a study that's been done quite a few times, and actually 40 to 55% of people remember sleep falsely. And this is sort of kind of a way to introduce behavioral insights to you. So our brain is actually quite clever in doing this. So we see a series of words like bed, rest, awake, drowsy, and you automatically associate that then with something like sleep because it all makes sense in a kind of heuristic in your mind. So it's quite clever, but it's actually a kind of faulty way of thinking. And there's a series of, so we would call these behavioral insights. There's a series of these kind of mistakes that our brains make, but they're often very predictable and they can be overcome. And that's really what's at the heart of the behavioral insights team, is to try to help people understand these kind of mental shortcuts and help make better policy, help people make better decisions, and help people make healthier kind of lifestyle choices. So the Behavioral Insights team began in 2010. We started in Cabinet Office at Downing Street number 10. And our main mission, we were the first government body really dedicated to using behavioral insights and applying it to public policy. And since 2010, we started with about 6 employees in a kind of small room. And since then, in 2014, we spun out of government, and now we're a third owned by Cabinet Office, a third owned by Nesta, which is an innovation charity, and then a third owned by BIT's own employees, which means we still work really closely with government, but we have a little bit of flexibility to work on kind of different projects. But our mission has really stayed the same, so we try to use behavioral science, behavioral insights, which I'll explain more about in a minute, to help people make better decisions for themselves. So behavioral insights is a term we kind of coined in around 2010, and essentially it's findings from a series of different fields like psychology, economics, public policy, and using scientific methods, all combined together to, again, try to understand how people actually behave in real life rather than how we assume they behave, so that we can design public policy better and more efficiently. And how many of you know Daniel Kahneman? Not personally, obviously, but if you do, that's very impressive. So Daniel Kahneman is, a lot of our work is predicated on kind of his thought leadership, and he's a Nobel Prize winner in economics, even though he's a psychologist. And he came up with these 2 systems of thinking. So system 1, if I asked you what's 2 times 2, go ahead, shout the answer.
It's not a trick, do I?
4? Yeah, this one's not a trick. 4, right. So for most people that comes quite intuitively. You don't really need to think very much about it, and it's very effortless. This is also the kind of system of thinking that we use when we're doing rote things like traveling to work. You can text while you're walking, you can multitask, even though you might not be as efficient as you think you are. But basically, system 1 thinking is just your fast, automatic thinking, and we have to use this quite often because life is complex and there's a series of different demands on us every day. System 2 thinking, however, I would love if someone could answer 24 times 17 off the top of their head. There's always one.
I worked it out.
You work, but you saw it before. Okay. So I've done this a few times, and I have shown it quickly, and people can work it out. But most people, it takes a bit longer. So, system 2 thinking is the kind of slow, reflective, and analytic thinking. So this would be like many of us over the Easter holidays, planning a trip overseas. Or you need to put a lot more effort and kind of cognitive reflection into this. And why does this matter for public policy? Well, the reason is, so policymakers, we hope, tend to make policy using system 2 thinking. So let's take, for example, HMRC. They're coming up with a new tax policy. So they sit down, they're being really deliberate, they're being really thoughtful, they're thinking about what kind of tax incentives they're going to offer. And then they assume that the end user, let's say myself, is going to receive this letter, and I'll also be in a state of system 2 thinking. That I'll be able to get home from the office, I've had a great day, all my emails are answered, I'm not tired at all or hungry, I just have one piece of post, I open it, I can understand everything perfectly, and I pay my taxes on time. This is what we would like to happen, but that's not reality. So they assume that we were in system 2 thinking, but actually I'm coming home, I probably had a lot of terrible emails, I'm usually very hungry, and I have a ton of posts to get through. If I see something from HMRC, I usually kind of just push it aside. So I'm not taking the desired action that they would want me to. And so what we try to do at the Behavioral Insights team is to really challenge policymakers and challenge different organizations to think about what kind of heuristics, what kind of mental state the end user is going to be in to enable them to make the best decisions possible. And as Daniel Kahneman said, it turns out that the environmental effects on behavior are a lot stronger than most people would think, which is no surprise to many of you, I'm sure. And when it comes to patient safety, this is quite relevant. So as many of you would know, there's a lot of biases that can happen within doctors. So for example, the availability heuristic is a behavioral insight where people tend to judge the frequency of an event or behavior by how easily it comes to mind. So for example, if you just saw a patient who had a rare kidney disease, you may go to the next patient, and because they present similar symptoms, and this was recently in your mind, you might diagnose them with the same kind of rare disease because that was kind of top of your mind. So that would be using availability heuristic. Representative heuristic would be something like if a woman comes into your office as a clinician and she says that she maybe say has missed her period, she's having some kind of cramps or bloating, you might automatically assume she's pregnant. So this is making assumptions based on stereotypes that we have. Some of them might be useful, some of them might not. And we jump to conclusions oftentimes when using these kinds of heuristics. And then cognitive overload is another behavioral insight, which we all deal with. And it's basically just we have so much going on. When we have to make so many decisions every single day, it really limits our ability to kind of tap into that system 2 thinking and to really slow down and use deliberate kind of effortful thinking, which oftentimes makes us, again, jump to conclusions and rely on these kinds of heuristics. But I'm sure, as many of you know, these are actually beneficial a lot of times in medicine. So you don't always have time to sit down and take 20 minutes to think about a patient when they're right in front of you and they're experiencing chest pains. You have to act quickly. So heuristics aren't always bad, but it's worth noting that they do exist and trying to think about sometimes ways that you can overcome them. And when it comes to patients, patients also have biases, so we're all human. Patients often have present bias, which means that people tend to overvalue the immediate reward versus the expense of long-term intentions. So for example, I would rather eat cake right now because it tastes very good rather than worry about getting diabetes in 20 years. So the present reward of cake is much more salient to me, therefore I'm much more likely to engage in that behavior. And so as doctors, as clinicians, you can oftentimes try to make those kind of immediate rewards more salient or more available to them by highlighting the benefits of stopping smoking and making it seem more present to them. When it comes to procrastination and deliberate ignorance, a lot of patients kind of have a fear of negative outcomes, so they may delay a patient taking an action on a health matter. And for this, we usually would recommend that if a patient is in your office, for example, if you want them to stop smoking, that you know they're a smoker, the best time, we would say, is to get them to sign up to a stop smoking program right then and there. So we call this making something timely, which Alix will refer to in our EAST framework. So trying to kind of get them to stop procrastinating and making the moment as timely as possible. And then friction costs are incredibly powerful. So friction cost refers to basically anything that stands in our way of doing the required behavior. So for example, the door not opening, maybe I just wouldn't have come in and it would be like, actually it's late, I could go home and get some takeaway. So that door not opening is a friction cost and I'm just gonna go home. In real life, this is obviously could be play out in a series of different ways, but for example, if you have to click through on an NHS website, 10 different times to get to the form you want to fill out, you're much less likely to uptake the behavior. So whenever possible, trying to eliminate any kind of friction that there might be between the desired behavior and getting there. And so these all kind of biases play out in how we care for our patients and how our patients respond to the care that we're giving them. And now Alix is going to talk you through what we love an acronym at BIT. So we have two of them we'll talk through today, but this is the EAST framework, and this is how we apply these kind of behavioral insights to meet a variety of different challenges.
Thanks. Hi everyone. So as Emily said, I'm going to spend the next 10-15 minutes or so talking you through our EAST framework. And the EAST framework, as Emily said, is something that we created in-house at BIT. And the idea behind it was just to create a simple tool for policy officials who maybe aren't familiar with behavioural insights to use when trying to apply behavioural science to common policy challenges. And it's available on our website if anyone would actually like to read it. It's a full report. But in essence, what the EAST framework states is that to encourage a behaviour, you need to make that behaviour easy, attractive, social, and timely, or any combination of those. And it's by no means a kind of comprehensive overview of behavioural science and how to apply it to public policy. As Emily said, she's just run through lots of things that aren't at all included in our EAST framework. But the EAST framework includes some of the most frequently used behavioural insights when it comes to policy challenges, and also some of the most effective ones that we've seen in trials in the past. So I'm going to talk you through a bit about what the EAST framework speaks about under each one of these categories, and then I will move on to give you a couple of examples of the work that we've done in the past with Imperial and with the Department of Health and Public Health England to show you how we've sort of applied these ideas in our day-to-day work. So starting with easy, starting with easy, as Emily was speaking about earlier on, this could be, for example, removing friction costs. So if we want to encourage someone to do something, we might try and make it as easy as possible to do. This is really making it easy in its purest essence of if you remove all the hassle involved in doing something, it's much more likely that someone will do it. The second one here we can have is simplifying messages. So I know, for example, if I get a letter, sorry to bully HMRC, but if I get a letter from HMRC, sometimes I have absolutely no idea what they're asking me to do. It's 4 pages long. I'm not entirely sure where I'm meant to direct my attention. And actually at BIT we've done lots and lots of work on just really cutting down those sorts of letters, all sorts of communications from all sorts of public bodies, just to really make it very clear what the person receiving the letter or the email is actually meant to do based on that particular message. And one of the other things that the EAST framework talks about in this category is using defaults. And now these can be really powerful tools in applying behavioural science. And this is, I'm sure you'll be familiar, very frequently talked about in terms of pension schemes, automatically having people enrolled in pension schemes as opposed to having an opting-in process. And also, more recently, what's coming up in discussion a lot and what's about to go through is obviously an organ donation, the registration of opting out as opposed to opting in. Moving on to attractive, some of the principles that the EAST framework talks about is, for example, attracting attention to either the behaviour that you want people to do as an attractive thing, or just attracting attention to quite important information that might make people think, actually, I should probably be doing that. And at BIT, we applied this to try and reduce do not attend rates at outpatient appointments by adding, I'm sure maybe you've had them in your GP reminder text messages, that if you miss this appointment, you'll cost the NHS £160. We found that just adding that one phrase into the reminder text message for the appointment reduced do not attend rates by about 25%. So just one extra line had a very big impact. Another thing that the EASE framework talks about is personalisation. So I know when I get an email from someone, if it says Dear Alix, I'm much more likely to 1, read it, and 2, do what it tells me to do, as opposed to if it says Dear whoever, Sir, Madam, whoever. So we've used that quite a lot as well in our communications work. And another thing that the EASE framework talks about in this category is the use of rewards and incentives. And here I don't mean just saying we've got a pot of £10,000 that we're going to quietly give someone or to everyone who does this particular behaviour. We try and use existing rewards and incentive schemes that exist and try and tailor it to be as effective as possible. So we'd say maybe entering 100 people into a lottery where one person can win £100 might be more effective than just giving everyone £1 each. Moving on to social, I'll talk you through an example of how we've applied this. But this really just draws on the idea that people are, at their core, social beings. There's a really great example. I'm not sure now if it's actually true or if it's just kind of a wives' tale of a fantastic experiment where they were videoing a lift. And actually what the experimenters did was to fill the lift with actors. You know, when you go into a lift, usually you go in and then you turn around and you face the door so that when the door opens, you can walk straight back out. And what the experimenters did was to fill the lift with actors, and instead of the actors facing the door, they got all the actors to face the back of the lift. And then they filmed unsuspecting people coming into the lift to see what they would do. And sure enough, everyone who walked into the lift saw all the actors, obviously thought there must be a reason why they're all facing the wrong way, and so walked in, would sort of look around, look at the door, and then think, no, okay, cool, I'll face this way like everyone else. No sense behind it. So it just shows that people don't like to be in the minority, they like to do what other people do, and if you highlight that people are doing something different to the majority, using social norms, that can be a really powerful way of getting people to change their behaviour. Similarly, messenger effects is just the idea that if you have an influential or a very relatable messenger, that can actually have a really big impact on how a message to undertake a particular behaviour is received. And finally here, there were a couple of points in the EASE framework about reciprocity and commitments. And reciprocity is the idea that if you do me a favour, I feel quite obliged to return the favour, and actually it's quite likely that when I return the favour, that will actually be of a much greater magnitude than what you did for me. And we've drawn on this idea, for example, in our organ donation work. So we've encouraged people to register by including just one sentence in the DVLA webpage where people are encouraged to sign up to organ donation, saying, if you needed an organ, would you have one? If so, please sign up to become a donor today. And we found that significantly increased the number of people registering to be organ donors. And finally, commitments is what it says on the tin. Just if people commit to something, they're much more likely to actually do it than if they haven't committed to it. And the more publicly and the more formally you can get people to commit to doing something, the more likely it is they will actually do it. So we've used this, for example, to increase the rates of job seekers actually finding work and coming off benefits. And finally, timely. So this is the idea that if you time your intervention at a particular time, it might be more effective than if you time it at another time. So timely prompts, so prompting people to do something at the actual moment where they're making that decision is probably the most impactful time you can ask people to do something. If you ask me to do something 3 weeks before the event, I might well say, yeah, sure, I'll do it. But when it comes to actually doing it, I might not follow through on that. Similarly, getting people to plan how they're going to do something helps people move from intentions to do something to actually actions doing something. And finally, temporal discounting refers to what Emily spoke about earlier on, of that idea of present bias. So things in the present now seem a lot more important than maybe distant long-term consequences. So it's about trying to really bring to light those long-term consequences to people to try and encourage that balance to shift a little bit. So a few examples of how we've done this. The first one I'd like to speak you through is a trial that we actually did with Imperial that was written up in 2014. And this was about trying to reduce medication prescription chart errors. And at the time when this study was done, medication errors were thought to affect about 50% of hospital admissions that were using paper drug charts. Now obviously I know that we're progressively moving towards electronic prescribing, so some of this is becoming less relevant the more we move towards that. But I think the point of applying behavioural science still remains very valid. So what we did here was, this was the old paper drug chart. I'm sure many of you who are clinicians will be familiar with something that looks a bit like this. So you've got, obviously, you write your drug, you write the dose with the unit of measurement in the same slot. You have an area for the dose and there's for frequency. And again, people were sort of needed to write the sort of times of day that they wanted to have the medication given, but sometimes that didn't happen very much. And again, the signature of the doctor and the bleep number, again, was all sort of in the same box, as you can see. And then what the researchers did was to just change the chart a little bit, just to make it a little bit clearer and to simplify the information that's presented. So as you'll see, there are a few changes. You had to circle your unit of measurement. There was now a specific box saying I want it once a day, twice a day, 3 times a day. And there was also a separate box for the bleep number. And just by separating it all out, the idea was to increase the legibility of what was written down on these drug charts. And this is the prescribing errors using the old drug chart. So as you can see, the number of times the dose was entered correctly in the old drug chart was 95%. The prescriber's contact number was entered 32% of the time on the old chart, and the frequency of the medications was entered correctly 9% of the time on the old chart. Do you think the new chart made things better, worse, or the same? Better? Anyone for worse? No, okay, well, fine. So this actually, our chart completely removed the dose errors that were entered. Just again, going back to it, we just had the separation of the numbers and the unit of measurement that was actually a separate thing so that you didn't have it all scrawled in the same box. This one actually made a very big difference. Just having a separate box for people to put their bleep in as a bit of a nudge to say, you actually have to fill this box out and you actually have to put your bleep in here, was really effective and, as you can see, made a huge difference. And finally, the frequency of medication errors also went up a huge amount just on the new chart. So just being able to circle OD, BD, TDS, that made a massive difference on the new chart too. So it just shows that just slight tweaks to an existing system costs very, very little, can actually have a huge effect on patient safety in this case. And the second example I'd like to talk you through is a little bit less linked to patient safety, but I think just describes lots of the behavioural concepts that I've spoken about really clearly. So this was a trial that we did with the Department of Health, Public Health England, and the Chief Medical Officer in 2013-14 over that time. And the idea was to try and reduce the number of unnecessary prescriptions, antibiotics prescriptions prescribed by GPs. And so how we went about doing this was to actually look at data that is publicly available to all GPs and all doctors. And so we clicked on it to try and see the prescribing level data. And actually what we found was that the file was so large that it crashed our entire computer system. So actually no one was looking at this data because it was impossible. So after a few computer reboots, we actually finally managed to gain access to it. And we managed to identify the top 20% of GP prescribers. And we randomized that group into the treatment group and the control group. The control group got nothing from us, no communications. The treatment group, we sent this letter to. Give you a moment to read it. So the things to highlight here were that we used this idea of social norms and we built on this idea by sending this group just one line, quite near the beginning, in bold, saying the great majority, 80% of practices in that particular area that the GP was working in, prescribed fewer antibiotics per head than yours. The second thing we did was to give GPs 3 easy steps for how they could go about maybe not giving a particular patient an antibiotic prescription if they didn't necessarily immediately need one. So that was advice on self-care, the idea of delayed prescriptions, and also potentially discussing the prescription with a colleague. And the last thing that this letter included was that it was signed by Sally Davis, who's the Chief Medical Officer. And this was again drawing on that idea of the messenger effect. So if you have an influential messenger, someone is much more likely to act on the information that's being given. Also, Sally Davis, as a clinician herself, was also a very relatable messenger to lots of the people who were receiving the letter. What do you think happened? Did the letter do better than nothing at all? Just one letter. We ran the trial from October to March, so over a winter period. Do you think the one letter received in October made a difference?
Maybe short term.
Short term, okay.
Yeah.
So short term, how long do you expect that it would work for?
2 to
Okay, so we're thinking till the end of the year, January? Sorry to put you on the spot. Okay, so what happens is, so we actually measured just before we sent the letter in September, and we also measured after the end of the trial, and I'll talk you through it. So this is the control line. So as you can see in September, it started quite low, and then there was some seasonal variation as we'd expect. And this is the treatment line. So what you can see is that in September, before we sent the letter, the antibiotic prescribing rates in control GP surgeries and treatment GP surgeries were the same. And actually you can see at all time points over the 6 month trial duration, the treatment group has a prescribing rate lower than the control group. And actually this is about a 3.3% relative difference, which when you think about how the...
Not uniformly, sir.
Huh?
It's not uniformly. The graph has come down, but not uniformly. Between
Yeah, it's...
November to December,
yeah.
it's a lot closer to the control than when it's away from it.
Yeah, it is. So on average, obviously, it's 3.3% relative decrease. But it's statistically significant at every time point that it was measured. It was measured at the end of every month. And a bit like you, before we went into it, we thought this is one letter, it might work for a little bit, but I think we were a bit surprised, actually, that it worked for that extended period of time. And so what we wanted to do at the end of the trial period was to see if actually it was our letter, if we could kind of double confirm that it was our letter having that effect. So what we ended up doing was sending our letter to the control group at that time. So by that point, everyone then had the letter. And we actually found that the difference between the two groups disappeared, which was really encouraging that actually it was our letter that was creating this difference between the two groups. And we calculated that if at the beginning of the trial we'd sent our letter to every single GP practice, so control and treatment, it would have reduced England's antibiotic prescribing rate by 0.85%. And given that the quality premium rewards a 1% decrease, this is actually a pretty huge difference for a trial that only costs £4,000. So that was great. And so in terms of what that means in the larger scale, so our trial managed to save 73,000 odd doses from being prescribed from the treatment practices. It had a direct cost saving to the public sector of £92,000 plus pounds. And this is what I said earlier on, that had we sent the letter to everyone, it would reduce the prescribing rate by 0.85%. Does anyone have any questions on that while we're here?
How do you calculate the 0.85%? Because you were sending it to the top 20% of
Yeah.
prescribers. I mean, you sent it to the bottom 20%.
So this was just, had we sent the letter to, in our top 20%
So only
band,
to the
to the control and the treatment groups. And actually it would have had that level of effect just by sending it to our top 20%. But the full top 20%, if that makes sense.
Was there a follow-up of any kind after you sent the first letter? Maybe a second one congratulating or otherwise?
No, so that there wasn't actually a follow-up letter to say, well done, you've reduced your prescribing.
Congratulate people who've done well.
Yeah, it could well do, and feedback is one good way of doing it. You've got to be quite careful with feedback, how you present it, because sometimes if you say to someone, you're doing a great job, they get a lot worse quite quickly. Yes, you have to be a bit careful of how you do it. Great, I will pass back to Emily to talk about burnout.
I think, did you have one question?
Oh, yeah, I mean, it's not super important. I was just interested whether there was a lot of variation across the doctors. I'm not sure if you can see it in the data, but whether some of the doctors actually made a much bigger difference than the 3.3% and some didn't change at all, whether it was sort of a compounding effect of once that habit was ingrained.
You know what, I know that is definitely in the paper, which I've put the citation on here so you can have, but I can't remember off the top of my head, and rather than maybe fudging it, I would just rather, it's definitely there, though I know it is.
Can I ask too, if you know the top 20% today, how consistent is that? I mean, do people move backwards and forwards? Presumably they do.
So,
It's not always the same people.
yeah, so actually what happened was that when they were doing that, they actually controlled for the number of antibiotic prescriptions that happened the year before, because obviously it's completely understandable that in some areas, you know, depending on the demographic of the population, you have much higher antibiotic prescribing rates in some places than others. I think it must vary from one place to another, but I think they only looked at the rates the year before. So I don't think they looked at previous data to see if that was fluctuating or not. This was kind of more of a snapshot of, at the moment, you're in the top 20%.
I think it's worth also mentioning that similar things were done in Australia, so I think it's the first time we've done, where they sent out letters, they started adding an element of personalisation
moving on to the next acronym. So EAST is how we apply behavioral insights to meet a variety of different challenges. But when we're commissioned to work on a specific project, we have a methodology which we call TEST. Very excitingly, we added an S, so it's now TESTS. And the extra S at the end stands for scale. So we were commissioned by Imperial and the pstrc to try to reduce burnout. And we use this methodology, so we work through targets, so first trying to define the problem and also what kind of measurable outcomes we can get. We then go through a phase of explore work where we try to analyze any existing data on the issue and also conduct qualitative interviews and site visits in this case, which I'll talk you through. And then we come up with a long list of solutions, behavioral solutions, and we kind of give that to our partners and see what we think might be feasible. We do a bit of feasibility impact, and wherever possible, we try to run it by the end user as well, which we did in this case. And then we eventually launch a trial. So I think it was probably worth me saying at the beginning, one of the kind of key components of BIT is that we try to do randomized controlled trials whenever possible to make sure that we're using the gold standard of evaluative methods, which Alik's highlighted. So I'll just walk you through a little bit of how we've gone about doing this. So the first thing we needed to do was to identify a target population. So at the very beginning, it was just open to reducing burnout in medics in general, but we wanted to be much more specific. So what we did was look at the GMC data, and they measured burnout proxy measures. And we tried to identify the top 10% of professions of medics that were in this kind of high risk for burnout category. And anaesthetists were in this. And then also the RCOA had recently published a paper talking about the risk of burnout and that they really wanted to try to prevent this, and they were very enthusiastic partners. So because of these two things, we decided to partner with the RCOA, and our target population became anaesthetists in training. So the overall goal of this project is to try to reduce burnout in anaesthetists in training specifically. So that's kind of our target. And then we conducted 3 different exploratory activities. We did phone interviews with trainees, so we sent out a call to anaesthetists in training to see if they wanted to participate in an hour-long conversation with some strangers from the Behavioural Insights team. We got actually a lot of responses, and we did kind of semi-structured interviews with 14 trainees from a variety of different deaneries, so we tried to get a mix of kind of all over the UK. And then we also interviewed 1 trainee mentor. And then we did frontline shadowing actually here. So we were able to go in and see the theater and the emergency department to see what it actually looks like in practice to be an anaesthetist, which I found out is something I shouldn't do. Don't love blood, wasn't fantastic. And then we did desk-based literature reviews. So we tried to look at what else has been done in this space, what are some protective factors for burnout, what are some predisposing factors, and what are some evidence-based solutions that have been used in the past. So just to give you a few quotes from the kind of the interviews that we did, that I think really highlight some of the issues happening. I won't read all of them to you, but the first one is medics think that they have to be okay and have to be okay with the things they see, and so they don't ask for help. So I think there was this culture that we heard over and over again of having to just get on with it. This is, you're a medic, you're an anaesthetist in training, life is hard, just, kind of keep calm and carry on. And so they didn't really stick up when they're having issues. Another person said that NIHR don't really see you as an individual, they see you as a bum on a seat. So highlighting this kind of not feeling valued as an individual, especially as a trainee. And the thing that stood out, I think, a lot to us was we asked them, what makes for a good or bad work rotation for you? And over again, people highlighted the fact that if their consultant was understanding or empathetic, that made for a really good rotation. Or if the people around them, if they felt like there was social support, that made for a good rotation. So these were the kind of things that stood out to us the most from these qualitative interviews. And so together, I don't know that you can really read this, but Alik's made this lovely chart. And basically we took our fieldwork findings and our literature findings, and we try to see what are factors that protect people against burnout. So you can see, I might have a, oh, lovely. So factors that protect you against burnout. So from our fieldwork, having a shorter commute, having your basic needs considered, and consistency of work location and colleagues were things that would protect people from burning out. And that was what we found in the fieldwork. From the literature, we didn't really find any from system-related factors that would protect you from burnout. Work and team-related factors, so this is more intrapersonal relationships. What we heard in the field was that having adequate support, again, from seniors, good relationships, good social culture, and getting positive feedback. And then from the literature, we found good leadership, autonomy, opportunities for job development. And again, I won't read all of this to you. A lot of the things that we found, I think is worth noting from both fieldwork and literature, is that many of the things were structural barriers. So things like not having beds to take a rest in, or not getting your rotation on time. So here are kind of a few of the things that we found. So we did make some recommendations to NHS, and within the constraints of the kind of current system, there's a few things we think could be feasible that bit necessarily wouldn't change, but that could be changed, we think, and it wouldn't maybe cost too much money. But we heard over and over again that ARCP requirements change all the time, so people don't know what they need to submit, and it's quite stressful. They said rotas were not distributed on time, so people never knew when they could take holiday or when they need to take leave. And another thing is having more local exam settings, so some people have to travel really far distances, obviously, to take their exams, and they also cost quite a bit of money. And shorten the time to resit, so you have to wait about 6 months in between resits for exams if you fail. And one of the suggestions was to shorten that amount of time. And another thing that came up was there was just no well-being supervisor. So someone who was independent from their actual academic progression or training to look out for them, or to maybe help debrief after a kind of traumatic experience that they might incur. So these were some things that we thought within the constraints of NHS might be feasible to change. There were then further system-wide changes that would be extremely impactful, but things that might be difficult to implement. So obviously reducing workload would probably help reduce burnout. Reducing the commuting distance would also help, and also continuing innovative work on rota systems is going to help as well. But it's worth saying all of these things are outside the scope of what the Behavioral Insights team does. We, again, from the examples we showed you, we usually come up with quite small interventions, or some people call nudges, that are based on behavioral barriers and not these large structural challenges. So these system-wide changes were quite outside the scope of what we were looking to do. But as I said, we did kind of, from the Explore work in the literature, the things that stood out most to us were people not feeling valued, a lack of social support, and also anaesthetists specifically said they oftentimes don't get to get the kind of gratitude from the beneficiary. So they put people to sleep, and then they don't normally get to see them when they wake up oftentimes. So they don't get to have that like one-on-one interaction, and they don't get the gratitude that contributes a lot to meaningful work. So what we decided to do, our intervention we came up with after consulting with a few different groups, was to actually come up with some behaviorally informed text messages that we'll be sending out to anaesthetists in training. So these are based on kind of trying to boost people's feelings of being valued, and they're based on kind of well-being literature. We have things like mindfulness. We also have collected stories from patients in the past who highlight the importance of anaesthetists. So we'll send out stories to anaesthetists saying, how much that really made a difference to them. We have gratitude from an influential messenger that will be sent to them as well, and these will be sent fortnightly. So again, we'll have a control group, and we'll have a treatment group, and we'll take 3 measurements, which I can highlight here. So at the moment, we've come up with the intervention, which is behaviorally informed text messages to try to boost well-being and decrease burnout. Our 2 primary outcome measures are the Copenhagen Burnout Inventory and then the Edinburgh Wellbeing Scale. which are short item measures. So we'll start recruitment in August 2019, so quite soonish. And then once we recruit the anaesthetists, we'll randomize them into treatment and control. The control will get guidance to self-help literature that's already available on BMA, and everyone will get a baseline survey. Then the randomized control trial, so the participants who are in the treatment will get text messages fortnightly from August to August, and we've taken into account especially times that they have kind of high pressure times, so ARCP times, also exam times, so we've tried to take into account making sure we're sending really timely messages at each point for each trainee. And then we will be collecting data at midline to make sure there's no backfire effect, so we want to make sure that we're actually not making people more burnt out or increasing anxiety in any way, so we'll take midline data and then we'll collect data at the end of the trial in August, and finally we'll report on any results that we find in November 2020. So that's sort of the intervention we've come up with. We'd love to hear your feedback, thoughts, questions, comments.